Good morning, everyone. Hello and welcome. My name is Therese Lloyd, and I work in the improvement... this isn't starting very well, is it? The Improvement Analytics Unit at the Health Foundation. And on behalf of the Nuffield Trust and the Health Foundation, I'd like to welcome you all to the Rapid Evaluation in Healthcare Conference 2023. This year's theme is Rapid Evaluation in a System Under Pressure. And as you all know, the UK health and social care system is under considerable pressure. And today is an opportunity to have a space to think about rapid evaluation within that context. So thinking about how we can support a system under pressure, how we can adapt our approaches given the context that we find ourselves in, and hopefully also provide some inspiration from some of the approaches that we'll be discussing today. We have a rich list of speakers and participants here today, everything from people from integrated care boards to academics, from local analytical teams to public participants, from teams that specialize in rapid evaluation to policymakers. And we hope that this conference will also be an opportunity to connect with others, to meet new people, and to share ideas and perspectives. And to that end, you'll find, if you've looked at the program, that we've got plenty of breaks throughout the day and opportunities to network. So I'll just quickly run by how the day is organized. So we'll start with a plenary session. After that, we have the first of our breaks that are followed by a choice of 3 breakout sessions. So have a look in the program and see which breakout session you'd like to go to. This is the Council Chamber, and then the other 2 rooms, which are the Oxford Suite and the Warren Suite, are on the 3rd floor. This is the 1st floor, so 2 floors up. There is a lift down the corridor if needed. Then there'll be lunch, and then after lunch there'll be another choice of 2 breakout sessions, and then we'll end with a plenary session back in this room, finishing for about 4:30. There is no fire alarm test scheduled for today, so if the fire alarm does go, please make your way out as quickly and as safely as possible. There are 2 exits. One is through the main entrance that you would have come in through. The other one is on the lower ground floor. But hopefully it won't come to that. But if it does, there will be staff around also to guide. And I hope you enjoy today. And I'll pass on to Sarah Scobie, who will be introducing and chairing the first session.
Thanks very much, Therese, and just want to add my own welcome to you all today. It's great to be here in person. I'm Sarah Scobie, and I'm Acting Director of Research at the Nuffield Trust. So it's very exciting to be here for what I think is the 5th Rapid Evaluation Conference. And over the last 5 years, the conference sessions have been a fantastic forum for sharing, learning, about how to do evaluations in a way that's timely, involves stakeholders, uses rigorous methods, and results in robust findings. So that's sort of the aim, I think, of rapid evaluation from my perspective. I'm sure there's going to be plenty of debate about that, though, as we go through the day. So I'm really delighted to be chairing the panel today, and we have a fantastic group of people to kick us off. So we've got Charles Tallick, who's Director of Analytics at the Health Foundation, Professor Judith Smith, who's Professor of Health Policy Management and Director of the NIHR Brace Rapid Evaluation Centre, Shona Haining, who's Head of Research and Evidence from the North of England Commissioning Support Unit, and Kate Morrissey, who's National Implementation Lead at NHS England. So we're going to hear from the panel in a minute, and then there's going to be plenty of time for questions and answers. So please, as we go through the panel session, please do start making a note of your questions, and then we'll have a chance to come to those. So just as Therese said, in the context that we're working in now, and the theme of the conference of a system under pressure, I thought it was just useful to just take a moment with your neighbour just to reflect on what you think working in a system under pressure means, how it changes how you work. So just take a couple of minutes just to introduce yourself to your neighbour and just have a couple of minutes reflection on that before we hear from the panel. 2 minutes. Thank you very much, everyone. I hope you've had a chance to, start to get your thinking and exploring and reflecting mind going. So, without further ado, I'm going to hand over to Charles, who's going to start the panel.
Thank you very much, Sarah, and lovely to see everyone here at this in-person conference. I was just reflecting with Kate how nice it is to have a printed programme. That feels quite novel rather than looking at your screen, and I don't know, the design of it, I don't know, it felt quite novel, so it's quite a nice thing. And I'm sure if I'd been able to listen to the cacophony or detect individual conversations, probably most of what I've about to say has been said somewhere in this room in the last 5 minutes. But we'll see. So, firstly, this is a session about evaluation in a system under pressure. So I just wanted to reflect a bit on those pressures, just to set the context. So I think, obviously, we all hear in the news every day about the pressures. So nowhere are those more apparent, I think, than in hospitals, and particularly for urgent emergency care. So we've seen, over the winter, and actually even before the winter, really long waits for ambulances, long waits in A&E, and there have been estimates about the delays that those are costing in terms of human lives. So I think there's an estimate from the Emergency Medicine College that it's about 500 deaths per week. That sounds pretty horrendous, but when you look at some of the excess death figures we've still got, that actually all feels quite plausible, particularly since there's no other obvious explanation for some of those. And the delays are particularly particularly acute for people who are admitted patients. And that's because it's very difficult often to find beds in hospitals. And the reason it's difficult to find beds on hospitals is because there are the demand pressures, but also we just haven't got enough beds. We've got very few beds compared to, say, France and Germany. I think we've got about a third of the number of beds per head as Germany. We've got 2 per 1,000. The French have got 3. So what that means is we've got a system which is operating at very high levels of occupancy. So whenever there's any changes in demand, it basically means it's really hard for people to find beds, and that creates delays. It's not helped either by the fact that there are, I think, about 13,000 people in hospital at any one time who are medically fit for discharge. That's 1 in 7 hospital beds. That is often blamed on social care, but I think actually the difficulties are much more than social care. There's nothing that says that social care suddenly got worse. I think partly this is the result of the pressures in hospitals. So when pressures on the hospital, it takes longer for staff to find beds for people who need them, and then they've got less time to spend on discharge. So these are really, really complicated issues and problems. We also see pressures, obviously, in elective care. So the figures which came out last week show there are now 7.3 million people on the waiting list. The thing I found most shocking was that the number now waiting over 18 weeks is 3 million. So don't forget, there is a right for people to be treated within 18 weeks. So that's 3 million. Looking back a decade ago, that number of people waiting more than 18 weeks was 200,000. So that's 15 times higher. That's absolutely extraordinary. So it just shows the pressures we're under. So that's just a reminder. So what happens? What does it mean when the system's under pressure? So I think a few things. Firstly, people want quick solutions. And what that sometimes means is that the ideas aren't as well thought through, solutions aren't as well designed, and too often I think they're trying to address the symptoms rather than the causes. So again, delayed discharge. It looks like it's a problem with social care because you think, well, where are people discharged to? Discharged to social care, discharged to care homes, or there's a need for care at home. So let's throw 300 million or 500 million at social care in the form of a discharge fund. So that sounds sensible. Actually, it's probably addressing the symptoms and not really the causes. And councils, the money's thrown at them so quickly, they haven't got time to plan, and they'll spend it not very well. And actually, DHSC evaluations of this showed that it didn't really have any effect in increasing capacity. So that's one thing I think we see. The other is that when ideas look promising, they are leapt on as being solutions, and then there will be pressure to then take those ideas and kind of adopt them across the NHS. So that's another thing I think we see. So faced with this kind of system, these issues, what does this mean for the role of evaluators, and more generally, the role of people who are analysts within the system? So I think the first, this is probably not so much about evaluation, but I think there is a need to be in the conversations early and to use, to kind of influence design of solutions. So help people by analysing what the problems are. And I think the role of evaluators here can be bringing out findings from previous evaluations. Most of the things that are tried have been tried at some stage in the past, and there will be lessons from that. Making sure that the results of all the good work we do in evaluation is born to bear on the current set of problems. So just as an example, our team at the Health Foundation did some work back in the summer on ambulance delays. And we went through all the issues. Is it demand for ambulances? Is it the number of ambulances and paramedics? The answer to those, no. But what we found was that because lots of ambulances were waiting outside hospitals, that was actually reducing capacity by, say, 10 or 20%. But because this is a complex system, that had massively magnified effects on response time. So they didn't increase by 10% response times, they increased by 100% because of the non-linearities in the system. So we did work on that, which, I think we had some perhaps influence on the debate because we found some of our work reflected in the Urgent Emergency Care Recovery Plan. So I think there's a need for analysts generally to help influence the design of solutions. I think when ideas are beginning to be implemented, we should be using whatever data we can. So sometimes we think, well, the data's not all there to allow us to do an evaluation, but often there's enough of it there to tell us whether an idea is working or not. I also think that once an evaluation is casting doubts on whether things are working quite as well as expected, we should be getting that out there early. We don't really want to be having all our resources sucked up in just proving things aren't working when there's already data. We need to use evaluation resource, scarce evaluation resource wisely and get the most value from it. And then finally, I would say lots of the time when the system's under pressure, people are trying to fix the problems. There's lack of capacity and resource in the system to really think through some of the more innovative, strategic ideas that might actually lead to the sorts of shifts and new ways of delivering care that we need. So I think it's also up to us as people working in the system to help identify these ideas and bring them to the fore and make sure they're evaluated rather than just evaluating things which are the latest idea to fix a problem. So those are my thoughts on evaluation in a system under pressure.
Well, good morning. I'm speaking to you this morning as the director of one of the two original rapid evaluation centres funded by the National Institute for Health and Care Research 5 years ago. So the one which I lead is called the BRACE Centre, that's the Birmingham, Rand and Cambridge Evaluation Centre, and the other one on whose behalf I'm also sharing insights is the Rapid Service Evaluation Team, known as RESET, who are a collaboration between University College London and the Nuffield Trust. And the reason I'm speaking in that sense, I'm saying on behalf of the two centres, is that last year, the National Institute of Health and Care Research, the NIHR, asked us as two teams to write, to reflect and then write a chapter for their online methods collection, research methods collection. It's not quite yet published, but it's literally on the cusp of that. So we'll have to find some way, Therese and colleagues, to, as soon as that does come out, to send the link to all of you. But it's partly about the methods of rapid evaluation, but really importantly, it's about the practical things that you need to think about and do when you're putting together teams, when you're scoping work and undertaking it. So that's what I'm drawing on this morning. I'm just going to cover two things. The first, I'm going to say just something about how do we sort of approach this thing called rapid evaluation? How do we carry it out? And then secondly, this chapter that I've talked about, in fact, we called it an essay when we were doing it, but it's quite a long essay. But it concludes with 5 lessons for rapid evaluation, for undertaking rapid evaluation. So it's those 5 lessons that I'm going to absolutely highlight to you. So first of all, thinking about the ways in which we carry out rapid evaluation, I think for any of us, and there's lots of us in this room actually from the BRACE and RESET teams, and indeed I know from some of the other rapid evaluation teams that have subsequently been commissioned, we're often asked, what do you mean by rapid? It's one of those kind of existential questions almost. But I think, I hope these reflections are helpful. I think in terms of timescale, sometimes what we're doing is we're actually evaluating something at a very early stage in its innovation or its implementation. One example, we've done the BRACE Centre. We did a very early study of primary care networks as they were being set up. But it can also be a project that's actually got a very short timescale of its own, a very short evaluation. Other times, it might be a study that has absolutely got to be mobilised really quickly. And I think we've got experience in both BRACE and RESET of the call on a Friday afternoon from Steph Garfield-Birkbeck, who's here in the room. And we'll be underway by Monday with the scoping of the project. It sounds a bit drastic, but a very good example of that would be pulse oximetry at home during COVID-19. But also, it can be something that Charles mentioned just now towards the conclusion of his remarks, that it can be about the findings being shared really quickly and as you go. And there are all sorts of different ways for doing that. And again, we've got lots of experience of that, as indeed I know so many researchers have, particularly during and since the pandemic. And then just a second set of thoughts about this, how we approach rapid evaluation. It can also be about how the rapid part of the work relates to other research that's going on in the area. So, for example, a rapid evaluation sometimes might be a precursor to a longer study. And again, an example in the BRACE Centre, we did a study of mental health trailblazer teams in schools and colleges, and there's now to be a longer term study of that. That's a piece of work we did with the London School of Hygiene and Tropical Medicine. Secondly, it might be a follow-up to a longer-term programme of work. And again, there's been experience in the rapid evaluation teams, for example, of doing some quite rapid, almost like additional research, looking at some issues such as digital telefirst sort of practice in general practice and primary care. And another example of that, I know the RESET team did work on the special measures regime. Again, they'd done more on that in the past, but they did a follow-up rapid evaluation of recent developments. Thirdly, a rapid evaluation might be actually nested within a longer-term programme of work. And I mentioned the pulse oximetry at home work that BRACE and RESET did together, but we did a nested study within that of how that was working in care homes, so in the social care sector. And finally, of course, a rapid evaluation study maybe a standalone project, and we've got various examples of those amongst the, I think it's at least 22 studies that Brace and Reset have done between ourselves. So turning to the 5 lessons for rapid evaluation, and I think they particularly do hold true in this system under such extreme pressure at the moment. I mean, much of our work actually ended up being undertaken during the pandemic, but as we know, as Charles has just mentioned, there are so many other pressures on health and care at the moment. So the first lesson is the vital importance of scoping. Some of you have heard me say before probably, don't skimp on the scoping. Sorting out what is it you're actually trying to, what is it they're actually trying to do with the service innovation or development, and then what are the questions you would ask in an evaluation, and is an evaluation appropriate and possible? Does it need to be done? Charles's point about the evidence might already be there. It's absolutely critical, and there are some more rapid ways of doing scoping, but just to say with some of our studies, I think we've sometimes spent more time on scoping than we have on data collection. And that's about building relationships, it's about proper patient and public involvement, it's about planning dissemination as you go and having this really close relationship with those who will use the evidence ultimately. So scoping is critical to success and really shouldn't be rushed. Second, it's about being really transparent about uncertainty and limitations. Of course, there are trade-offs in rapid evaluation, as indeed I'd argue there are in all sorts of applied health and social care research. But I think we've got to be clear about where there are limitations and actually managing the expectations of those who are asking us to do the evaluation or who are working in the particular service development. So we've had the scoping, we've had the being clear about the limitations. Thirdly, it's about the need to harness the benefits of a team-based approach. This is serious team science, rapid evaluation. And again, we've had studies with 6, 8 people working in parallel, often quite senior teams as well. Because if you're going to work at pace but be rigorous and responsive as well, you're often going to be doing things that in a lot of research would happen sequentially. You're going to be doing them in parallel. So a team's important for that reason. Also, just for the sheer range of skills. The scoping work I talked about, the close working with evidence users, that's quite difficult to do. It requires skills that not all researchers will necessarily have. And also, you need lots of senior support to the teams to supervise their work, to quality assure it, but also just to support the individuals and make sure they feel part of the team. And particularly when a number of you, as has been the case in the last few years, are working remotely and undertaking the research in often a remote manner. The fourth of the 5 lessons builds on that one about team working. It's about rapid evaluation, skills and expertise. And there's a whole kind of emerging area in terms of development and training for rapid evaluation. Now, of course, some of the skills are those used in other evaluation and research, but there are nuances and special issues, I would argue, are related to the work being rapid. So having time and resource to support the teams around skills development, but also organisational development, bringing them together at fairly regular intervals to reflect on their practice, and doing that along with your patient and public involvement colleagues and some of your evidence users and your commissioners, that is all really important. The 5th and final lesson, it's about the importance of thinking about how you can work in a rapid and, yes, rigorous manner, but across all the stages of the evaluation process. And this takes us back to where I started with these different ways of thinking about rapid working. So it could be about the conduct of a study. So it might be how you're going to collect the data, how you're going to analyse the data. And there are different ways you can sometimes do that more rapidly or decide to do certain parts now and save some of it for later on when you might write things up for academic publication. There are different things there. All sorts of different ways of doing quantitative analysis more rapidly. Again, Charles hinted at some of that, about the data that's often actually already there. Chris Sherlaw Johnson, who's here today, has written a fantastic section of our methods essay about that side of things. Also, patient and public involvement. Now, that needs really careful consideration in how to make this rapid. And I know there's a breakout session, I think, on that I think you're leading, aren't you, Joe, my colleague from Brace, later today. There are trade-offs there, but just to say that some of our patient and public involvement contributors in Brace and Reset have reflected to us, they really like, in some ways, the faster, more responsive way of working. They actually, can anybody jump on a call at 4 o'clock this afternoon because we've got a real problem with this study about Telefirst general practice or something. There's pros and cons to it. It's not, and it's definitely not all accounts of despair at all. There's some really positive learning, but again, has to be done inclusively, responsibly, and we have to keep reflecting on that. And we are writing about these things. And finally, for the point about uptake and use of evidence, we would argue that right back at that scoping stage, when you're getting to know the people who are, setting up pulse oximetry at home or whatever it may be, you're talking from the outset about why do you need this evidence? What do you want to do with it? So you're then thinking about how do you want the feedback? And using the example of that project, that was a weekly meeting with the evidence users. So, and sometimes, so that's the time that needs to be used, different skills about the feedback, what to feedback when and how. Other studies have taken longer. Some of them have taken a year or more. But all have had elements of this rapidity within them, but always wanting to be rigorous, responsive and relevant as well. Because being rapid, responsive, relevant and rigorous are the 4 R's that we've also used to shape our reflections. So to conclude, above all else, you need to scope rapid evaluation work really carefully and inclusively. You need to share your findings as you go, and be prepared to do that in all sorts of different ways. And overall, you've got to be dynamic, flexible, and upfront with people about what you can and can't do. But the satisfaction of when you know some of your findings have made a difference, either in terms of helping a service go forward or sometimes halting something or causing a pause, I think has been profoundly satisfying for all of us, certainly in the Brace and Reset teams. And we're really looking forward to hearing your reflections and experience as well in the discussion now and throughout today. Thank you.
Good morning, everyone, and it's delightful to be here. It's delightful to be in a room with people and not see people on a screen, which is just fantastic. So I'm Shona Haining, and I head the Research and Evidence team at the North of England Commissioning Support. We primarily support the North East and North Cumbria Integrated Care Board. So I've spent my life in primary care, in commissioning, clinical commissioning groups, all these words we heard in the past that have now moved into that world of integrated care boards. The North East and North Cumbria is quite unique in good ways and not so good ways. It's the largest ICB. It covers 14 places, a place being a local authority. It covers over 3 million population. Sadly, it is one of the most deprived areas. So the challenges that the ICB have are vast. Coming along with the fact that they now have a 30% reduction in the running cost allowance, what they need to do in the challenging environment needs to be done with a slightly smaller pot of money. And I think we all know that wherever we are in the health and care service, that pot of money has never been big anyway. So, I think everything that we do has always got to look at, the pounds, shillings and pence. Sorry, I'm old school for here, the money and the cash envelope. What I really am pleased to hear about is that, what Charles said from a national perspective and what Judith said from an academic perspective really resonates with the work that we do in the North East and North Cumbria. So we have a research and evidence team, the majority of whom have further degrees, have masters and PhDs, the majority of whom have worked in the NHS, and we really understand that sort of sweet spot in the middle. You know, we understand the challenges of academia, we understand the challenges in the health service, and we try and sort of sit in the middle to do that research and evaluation and evidence gathering and spreading. I think I sometimes describe us as a bit of a dating agency because we absolutely can bring the right people and the right skills together. But I mean, we as a team have done a lot of rapid evaluations for our ICB and for NHS England. And I think really those 5 points, I'm really pleased. Actually, it sounds like we've been doing the right thing, and I really look forward to reading the paper. It is very reassuring. I wouldn't say that we've got any particular magic solutions. I think I'll pose a few questions today rather than give you some solutions, because nobody has got it all right. But just wanting to reflect that actually the ICBs have got a statutory duty to use the evidence from research for decision making. We may want to reflect how much they do of that. And I think the challenge that we have is that we all know, however wonderful the research is, we wonder how timely it is, because they've got to make those differences now. The challenges are now, the challenges are in this financial year, as all the NHS works in the financial years of April to April, the financial envelopes, April to April. So there's a lot of things that research does really fantastically, and I would never, ever say that it shouldn't be done, but it's just fitting that whole evaluative space along that continuum to find out where it actually fits. And I think I'd like to reflect, and it might come up later in some of the questions, is that although there's a statutory duty for research, there is no statutory duty for evaluation. So what is the risk appetite for using evaluations as part of that decision making? Will ICBs, will the decision makers, will the policy makers, will they have to wait until there is a Cochrane review or it's in NICE guidelines? Life doesn't happen like that. So what they've got to rely on, and they do rely on, is those robust academic underpinning, pragmatic, real-world evaluations that they can build into their cycle of work so that they can understand what works, what doesn't work, how it's working, etc., etc. And certainly for the North East North Cumbria, you know, there's a lot of things happen in the middle of, you know, Newcastle, in deprived urban areas. But trying to understand what does that mean in rural Northumberland is very, very different. So you've really got to understand a lot of the contextualisation of what's happening. We can't just lift and shift some of that evidence. So I think I want to talk about sort of potentially 3 solutions or parts of solutions that we have in the North East North Cumbria. And it's really picking up on what's been said before, in that what's the evidence that's already out there? I am never into reinventing any wheels, and some people think, well, if it's not done in Newcastle, we don't want to know. But that's not the case. There's lots of really good evaluative, good practice, as well as research. And one of the solutions that we've actually worked in from a North East North Cumbria perspective is making better use of our librarians and knowledge managers. We've got, as everybody has, some fantastic librarians. They all tend to sit in these big acute trusts, but actually the CCGs and the ICBs and the policymakers are not there. So we've sort of tried to utilise them more effectively. I remember the very first time we met all together, when we actually did meet all together, and I sort of said, so who's done a literature review on frailty? And about 2/3 of them put their hands up, and I'm thinking, well, frailty is one of our big agenda items. Why are we doing this so many times? How can we more effectively utilise those really key people and utilise their skills on the priority? So we've moved into having an approach in North East North Cumbria of trying to marry our librarians and knowledge managers with some of the priority, with frailty, with maternity, with mental health, etc., and have them round the table, because I think we know, in picking up on what's been said, is that actually being part of that conversation, understanding what's happening, is really, really important. And there are somebody in this room who's written some evidence and papers around how do people take up evidence. And it is from relationships, it's from people they respect. It's not from a summary that happens to come past your desk or on an email. So I think it really builds on some of the conversations around understanding and embedding those evidence people and the evaluators in that space to really understand what the challenges are, rather than sending the best academic paper ever on an email to somebody and say, this is what you need to do. So that's one area of solution. I think the other particular area that we're really lucky in the North East North Cumbria is actually how we can access and utilise the data that we've already got. We've built in Next a platform called Axiom that's a cloud-based platform that brings together primary and secondary data, originally for commissioning purposes, but now is used very much in that population health management, in that analytics space, and in that rapid evaluation space, where you can look at the evidence that is already there across different primary, secondary care, some linked data into social care, and how we've got the analysts that can do that on a quick and easy way that can give you the current state, but also look at that changing state as your implementation of change. And that's very much part of what the secure data environment will be for the North East North Cumbria, which will again enhance that whole research and evaluation space. So I think looking at the data and the analytic capacity and skills that are there is really, really important. Utilising that on what the single version of the truth and how we can do that effectively is really, really important. But I think my last point is really thinking, about the solutions, about working closely together. Absolutely reflects on what's been said. It was interesting, Judith was saying that it takes longer to scope than do some of the evaluations. And I would absolutely agree with you. Cannot spend too long scoping and trying to get to the answer. I think when people and systems are under pressure, they want the answer now. If I do this, will this save me money and will the patients like it? And can you tell me next week? No. But we can work with them. We can manage those expectations. We can give them those robust ways of gathering it so that they've got the confidence, which I think is another thing that they've got to be sure of. They've got really, really difficult decisions to make, but they need the confidence of the data, of the evaluation, of the evidence underneath it to put their money where their mouth is and actually commit to some real change that's going to make a difference to our patient population. So I think I would definitely say working to understand what the problem is, realistically managing expectations, and importantly, and it's one of the questions I always ask early on is, so what do you want the end to look like? Who's it for? How do you want to use it? I'm not going to send you a 20-page report that will never happen. How do we disseminate? How do we manage that knowledge exchange and that utilisation going forward? So I think really, from the North East North Cumbria perspective, we've got a lot of difficult challenges, as have many of you who come from other ICBs here. I think we absolutely need to get the rapid evaluation embedded, having the right conversations with the right people, giving them the assurance that people, whether it be our team, some of the academics, Brace, etc., and we work very closely with our ARC. So there's certainly a lot of people in that space, and just getting them recognising that they can really, through rapid evaluation of multi-method approaches, they can really find out some of the answers to make those really difficult decisions that they've all got to make over the coming weeks and months. So I'll be really interested to hear some of your experiences, some of your comments, some of your experiences to, how much people do value the evaluative space as opposed to the research space. I'm really just looking forward to spending the day with all the expertise that's in this room, and happy to have a discussion with people. And it's just great to be able to show that from one of an ICB's perspective, we are following the national lead, we are following what the academics tell us, and we can make a difference by doing quick, rigorous evaluations. Thank you.
Hi. It's great to be here, even though Charles has outed me as being really happy with having a paper programme. I'm not easily pleased normally, honestly. So my name's Kate Morrissey, and I'm the national lead for a service called Reconnect, and also Enhanced Reconnect, which is a care after custody service. So I work in quite a niche area of the NHS, I'd suggest. The part that is quite literally hidden away behind locked doors and big high walls. And health in the justice system is an area that we don't hear about very much, but it includes people who have some of the biggest health inequalities in the UK. They're people who have experienced stigma and disadvantage on multiple levels. And the usual rules of engagement don't tend to apply to this cohort. They don't seek out help. They may have spent many years within the criminal justice system. They're mistrustful of services, and they tend to be rather transient. They've often been fouled many times by professionals, and they're used to being unseen and unheard within the health and within society. Both figuratively and literally, you know, they're behind locked doors. So, believe it or not, we spend a lot of money on healthcare within secure and detained environments, and by that I mean immigration removal centres and prisons and secure children's homes and young offenders institutes. And we do that to ensure that people can obtain a quality of life and the health equity of health outcomes to the rest of the community. And actually, despite what you might hear in the media, we're quite successful at that. People who've never been in substance misuse treatment will come into prisons and they will engage in substance misuse treatment for the first time. If they've got asthma, other long-term conditions, they do incredibly well. And however, we've known for many years that when people leave prison, it can be an absolute point of crisis. They go from a place where they have their health needs met and are able to maximise and utilise health services to never engaging in community services. And we see it time and time again, and they come back just as poorly as the first time they came in. And we kind of didn't know what to do about it for a long time. But then in 2019, NHS England committed to doing something about this kind of turnover and this churn of people coming out of prison. And they committed £20 million per annum within the NHS long-term plan to fixing this and to improve the care of individuals as they leave custody. And I have to say that's turned into a bit of a 5-year journey of how we could see what we were doing wrong and improving that system and doing it with patients at the heart of that, both of the development of the service and the evaluation of those services. So when we started in 2019, it was kind of a bit wishy-washy. We had an idea, it was pretty simple. We needed to do more to support people leaving prisons or immigration removal centres to engage with community health-based healthcare. But in honesty, that was pretty much it. We didn't know what it would look like, who we would work with, how we linked to other services, and we couldn't really decide what the service should look like and what it should deliver. And so we decided to do the most important thing, really, which was to start with the people. And we'd ask the people that use the service what it should look like and what their concerns were and what would help them to address it. So we did this over 6 weeks in the late summer of 2019, and we did that by commissioning 2 service user organisations, User Voice and Revolving Doors. They're both expert criminal justice system lived experience organisations, and they undertook that work for us, utilising the skills of people who had actually been in prison and who were on probation to deliver a rapid evaluation of the problem and how we could fix it. Over the course of those 6 weeks, they undertook a number of focus groups, both in prisons and in probation offices, and did a survey. And in the end, they obtained the views of 150 potential users of the new service that we were developing. And if we didn't know what the service should look like, the patients really did. They told us in no uncertain terms what the issues were and how we could support them to continue care. We heard that the service needed to start within a prison. It was no good meeting someone at the gate, ringing them a week after they'd got out of prison. We'd lose them. the day they told us that we needed to support referrals. It was no good referring them to a mental health service, telling them where the local GP was. We needed to do more. We needed to handhold them. In some cases, that would mean meeting them at the prison gate and taking them to the service. Other times, it might mean calling them on the day of the appointment to remind them. They worried about other situations, such as homelessness and the fact that they could be moved around on probation's whim. And so they couldn't focus on healthcare. So they told us we needed to coordinate with other statutory services to make sure that their needs were met. They also told us they were worried about getting medication in time, and that despite their best intentions, things often fell apart. And so once they'd been released. And so we needed to accept referrals after someone had been released when things had gone wrong. So we took that information, we developed a minimum service specification, and we began to nationally roll out the Reconnect service. Unfortunately, it was April 2020 by that point, just as the pandemic came into full swing. I'm pleased to say that by the end of this financial year, we will have 100% geographical coverage of Reconnect services available in every prison and every geographical area of England. And we'd always planned to undertake a full evaluation of the service in that first year. So we had commissioned a CSU to undertake an evaluation. However, as you may recall, during the pandemic, we were unable to collect any data, which kind of left us with a problem. So we decided that we needed to think differently and to see how we could evaluate a service that had no data and that actually was working within two systems that were massively under pressure, the prison system and the health service. So we did what we'd done at the beginning. We went back to people with lived experience, and we asked them to do a qualitative evaluation of the services that had been rolled out. So that took place between December last year and March this year to explore how the Reconnect vision and the things that had been identified at the beginning by the lived experience groups had been delivered within the service. They led discussions, so all people who have been in prison, have come back out of prison, led the discussions and questions, both people with lived experience who were going through the services, the deliverers of the service and the commissioners of the service. They used predetermined questions and prompts when necessary to encourage the conversation. As is always the way with these things, and I think Shona mentioned, sometimes we don't necessarily want to know the results of an evaluation. I was quite nervous about getting the feedback back from the services. So I'm going to start with the good. Okay. They recognise that a major achievement of Reconnect is that both staff and volunteers have been able to engage with people that have been typically described as hard to reach, those who'd never turned up in services. And this was partly down to the high use of peer support workers in the delivery model. Some services had up to a third of the professional staff members who were people who'd been in prison and who'd come out and were now delivering on a professional level. Indeed, some of the staff had actually been using the service, been in prison in 2020, used the service, had come out the other side and were now delivering the service themselves back into the prisons and in the community. They recognised that staff were working well with partner organisations such as probation to make sure that people were referred to those other statutory services and that they're able to benefit from additional support from the Department of Work and Pensions around benefits and the local authorities around housing. But they also identified some things that we could do better, such as telling people in prison about our services earlier in the journey, because they felt that it maybe sometimes was a scramble in those last few weeks when people had a lot to think about. They said that we needed to integrate better with some of the prison-based healthcare services because they felt that sometimes there was a disconnection. And they recommended that services had better career pathways for people with lived experience. They recognised that the services that had the people that had grown their own workforce had really good engagement with the patients that they were serving, and they said that we needed to do more. They told us that we'd come a long way, but that we could and should do better. We're currently working our way through the lived experience evaluation of the service, and we're making some significant changes to our service specifications as a result. If we hadn't involved the lived experience in the design of our evaluation, the design and evaluation of Reconnect, I think the service would have looked very different to how it looked now. Myself in a room designing a service would not have thought of all the intricacies that we were told by people with lived experience. It would have prioritised our needs, the system's needs, and not the needs of the individuals that we wanted to access the service. And we wouldn't know which bits were working and which bits we needed to focus on. Because I think the things that came out of the evaluation that the lived experience did for us were not things that would ever have come out of data. We wouldn't have known these things. And I just wanted to leave you with a little thought. Patient and public involvement can feel really challenging. It can feel like kind of difficult and hard to achieve. But if we can do it in a prison and in an immigration removal centre, then it could and should be used everywhere. Because there's literally no point in having a service that meets the needs of the people, that does not meet the needs of the people it's trying to serve. And we'd be wasting our time, and most importantly, we know that resources are scarce. We'd be wasting them, and we wouldn't be able to have a real impact. So I'm just going to leave you with that thought. So thank you very much.
Thank you very much, Kate, and to all of our fantastic panel. I think we've really heard about all parts of the evaluation journey, right from thinking about the model of care and data collection, dissemination, so loads of rich ideas there to think about. So there's plenty of time now for questions, and Olivia and Jess will come round with the mics in a minute. And just because the session is being recorded, if you could wait until you've got the mic before you introduce yourself and ask your question, that would be great. So would anybody like to kick off with a question or a comment or a reflection?
Thank you. Catherine Boyle, Norfolk and Waveney ICB. It's a question, I think, to everybody in the room, a comment really, and to Shona. I was very interested the comment you made about knowledge management, because I think one of the challenges that unites us all in this room is that if you're trying to do anything rapidly, or even an evaluation, knowledge management is of all the evaluations that have been done, if we costed how much time we all spend as a community searching for evaluations that have been done and put behind the filing cabinet. And, you know, we all know where to go to look for them, but actually, wouldn't it be great if we could do something as a community around knowledge management, even if we had people together in this room who were interested in evaluation in the healthcare system, that we set up some sort of forum or something to share those evaluations so that when we have to do rapid evaluations, we've got a go-to place. Just an idea, a comment, and I don't know if other people have done similar things or have systems, but it's something that would cut down man-hours very significantly for those of us who are working in the field.
So that's a really good comment. What I might just do is take a second question, and then there was a gentleman at the front. Jess, there's a gentleman at the front. And so we can perhaps have 2 or 3 questions and then go to the panel for them.
My name's Will Ridge. I'm from the Leeds, West Yorkshire ICB. And my question is for the panel about developing capacity not within evaluation service, but more generalised capacity. So building that capacity within things like what we call pathway integrators, commissioners in the old world, and things like that, and just their reflections about how that can be done successfully.
Great. So 2 great questions to start off with on building capacity and knowledge management. Who would like to start? Shona, do you want to?
Yeah, is this microphone on? Yeah? Okay. Yeah, so actually 2 fantastic questions, and absolutely in the space of some of my thinking and my colleagues' thinking. I would absolutely love that there was one place to go to for any evaluations. I think if there's things that we can do as larger organisations or communities of people, I think that would be fantastic. I think I will reflect that we have a challenge when evaluations don't tell them the story they want told. They might not want it put out there. And I think I would certainly reflect that from a local ICB area. I would certainly reflect that from some of the work we've done with NHS England. And I think, personally, I think that's wrong. We need to learn from the things that don't work as well as learn from the things that do work. So I think there's something about a culture change, thinking about that, as well as a practical change. So I would very much welcome some kind of platform. I know we in North East North Cumbria try and where we're allowed to put evaluations onto our website. But that's not the easiest to find, I'm sure. So I think we just need to think about that. North East North Cumbria ICB have nominated themselves as part of a learning system, and certainly the paper that was in the book that's down there about learning systems written by a group of people is certainly looking at being adopted in North East North Cumbria. But it needs 2 things. It needs processes, but it needs hearts and minds. It needs people to actually think about how they can do it. So I would welcome it, and anything we can do collectively would be fantastic. Does anyone else want to carry on that first question then? For the second one? Yeah,
Judith.
Yeah, I just wanted to offer a couple of reflections. I just want, Shona, you talked about evaluation and research. And I know Naomi Fullup, if she was here today at Outings, we're absolutely clear. Evaluation is research. It is part of research. It's absolutely part of health and care research and methods. And I think that there's kind of it is an emerging science, but it is absolutely, that is the case. I think it's really important because we need to honour evaluation that's rigorously and properly undertaken in that way. And connected to that then, this point about the knowledge management, which is a really good point. So the National Institute for Health and Care Research does a lot of pulling together of evidence syntheses and topic alerts and things. I'm getting the language wrong probably, but there's a lot that's out there and a lot that gets shared on social media. But there is an issue though about how that gets into the general health and care services, I think, and that's a challenge for those of us in the research community. But the other thing, with one of my other hats on, sort of back at the ranch, because universities don't only do research, we do a lot of teaching and development. We've been having discussions, certainly in Birmingham, with Birmingham and Aston universities, together with our local trusts, about training and development kind of needs, basically, for the clinical leadership and management community across our region. And only, I say, a few days ago in a meeting, people were saying, actually, at quite everything from kind of like first line management, like running a ward or a practice or a service, people need to understand how to use evidence and access it. So I think, yes, we might need platforms, but I think these days, just as it gets into the whole territory of information, artificial intelligence, everything. But, those skills, I think, are critical. And I think, so there's something for me today about an alert to us all about the training and development side of things, and for everyone, not just those starting out, alongside the kind of how we build evaluative research.
Thank you, Judith. And would anybody like to comment? Charles, do you want to say anything about the capability and capacity building, perhaps? Have you got any reflections on that?
So was this about capability and capacity building, not so much in evaluation capability, but in the sort of demand side for it?
A little bit of both. I'd say it's... Thank you. Yeah, a little bit of both. From our perspective, it's a little bit about them being able to use and consume evaluations and turn them into action. But I think there's also something about, we're as I say, we're an evaluation service for Leeds primarily. We're actually 3 people. We're all sat in chairs at the front here. So we're not a very big service, and we've got a lot of stuff to evaluate. So one of the things that we're looking at is there a way that we can build their capacity so they can actually do relatively simple pieces of work as opposed to us having to do all the evaluations that happen in the place?
Yeah, okay, that is a really excellent question, I think. And it links a bit to Judith's point, I think, about building the culture, because I think one of the thoughts I had about building this, a knowledge management system is that, when I've looked in the past at, across, say, for example, a service change, looking at evaluations in the NHS, there's actually generally quite a small proportion of those which are of good enough quality. There's a lot of them which might lead you to the wrong conclusions. So I think, to me, there is something about building a capability to, not conduct advanced evaluations, be able to actually interrogate data and evidence robustly, and to know when it's telling you something useful and when it's not. And I do agree. I think there is. So that, to me, that would be the first thing. Equipping people with the kind of skills to be able to do kind of critical thinking, not advanced analytics. And then I think you're right that people, actually there is an ability for people to pick up some of those simpler things. My point about actually there is data there, like what can it already tell you? And so I think there is a filtering mechanism that lots of, people you're talking about can actually use. And, maybe on some things, if things are looking good, you could bring in other people like your team. But I think, I don't know how to do it, but I kind of know what I think should be done.
Can I? So I just wanted to pick up on that, and I think there's definitely something around. I used to be a commissioner, but commissioners, we get the data, and we go from the data, and I do think there's something around having that really clear idea that qualitative data can help explain some of those the quantitative results, and also can pick out when there might be anomalies. And I think that we really need to build the capacity and the confidence and courage for people to be able to say, well, the data's telling me one thing, and this is what we're being told by patients and by clinicians. And so I think that some of the capacity building in that area would be really helpful.
I think I would absolutely agree with what you're saying. I think there are some examples we perhaps need to consider and utilise a lot of the skills and the people that are already out there. So I'm thinking, I've already mentioned, some of the librarians and knowledge managers, but also thinking about your applied research collaboratives. Some of them have practice fellows, have people, there's embedded researchers, models, and I think it's moving into a culture and a way of thinking that it becomes part of the norm. So those people are around those decision-making tables, they're part and parcel of it, so that you three wonderful people are not a little silo in a corner of a building somewhere or at the end of a Teams call. But actually that whole conversation around the research and the evaluation and the utilisation of evidence becomes part and parcel of what they're doing. I think it needs to be that in everything from your business cases, as well as the financial envelope and what that means, you need to look at what the evidence says. You need to look at what the communities that it's serving says. And it just becomes part and parcel of what you do. So it's not about turning, and I think there's something about the language we use, and therefore it's not about turning everybody into academics and sitting them in that ivory tower, but bringing those skills to where it's needed. And that can be, certainly we're doing work through the RENG programme, the Research Engagement Programme that the NHS England have funded, that's around taking the research to the communities of practice of underserved communities to make them understand. So I think it's about taking that research, that evaluation, where it's needed, with the people that can build up the relationships and the respect. And I'm just going to pick up on what Judith says and maybe just be a little bit controversial in that I do know, academics do evaluation and it is part of the continuum. I think the challenge that we've got to look at is that a lot of evaluation does not go through what is considered the Health Research Authority and the NIHR agenda, and therefore is considered slightly differently in some cases, depending on where you're coming from. And so I think there is very good evaluations out there that haven't been done academically and don't sit within that NIHR environment. And lots of bits of good practice that we need to be bringing into the conversation. And I think it is a bit of a challenge. And the last thing I would want is that any evaluation has got to go through the whole rigorous HRA process. I don't want to bring any more process into stopping that. And I think we've got a challenge and a debate to be having about that. But understanding all of that continuum of gathering of evidence. And Judith and I probably have got a different view on this, but it's about just thinking about where all of that sits in that pragmatic world to get the evidence to where it needs to be at the time it needs to be, and also deciding what's good enough. And we could probably spend the whole day debating what's good enough.
Yes. So some really interesting points coming up. And I know that we've discussed the research governance in one of these conferences in the past. So there's some questions over on there. So we take a couple of questions again, if that's okay, and then come back to the panel.
Morning, everyone. I'm Steph Garfield from the NIHR. There are two things. Shona, the last bit that you talked about put me in mind of a very interesting article written by Tara Lamont and colleagues several years ago about the continuum of research and what's required when and the appropriateness of different study designs. And I commend the article to everybody in the room because I think it still holds true, even though it's quite an old article. I think the thing that we haven't perhaps mentioned yet is this idea of independence and the importance of not only rigour but independent research, because that of itself means that whatever your study design, be it quantitative or qualitative, it will hold up much more credibly, I think. So your continuum of evidence is both to do with who's done the research, for what purpose, and how independent have they been.
Thank you, Steph. And there's another question just there. And then I think there was someone at the back as well afterwards. Oh, two at the back.
Hello, Hayley Truman, Oxford Academic Health Science Network. Thank you for your talks. It was really difficult not to clap after each of you. I was like, no, put your hands down. A reflection and then a question, if that's okay. So the reflection is it's really heartwarming to hear how you emphasise that pause at the beginning, not to jump to solutions and that relationship building. And Sarah and I, when you asked your question at the beginning about a system under pressure, was about the lack of bandwidth that people have to think about things beyond their daily priorities, and actually that scoping and relationship building and psychological safety building with the team provides people to have a little bit more bandwidth to think, doesn't it? And the reflection is that coming from a quality improvement place, there's so much crossover, and that, you know, using those skills in that problem diagnosis phase and that scoping phase and evaluation is really helpful, and that they're a big resource not to be thought of in silos away from evaluation teams, but actually a great resource to draw upon within trusts, within ICBs, where there is that QI capability. I think that my question or posing comment is around translation into frontline practice, and that semantics and language are really important, because when we use the word research, often that puts people off because it's seen as this thing over here, and it's seen as academic and daunting. And the same with evaluation, you know, it's something different. So thinking about how do we support people beyond perhaps their fixed mindset ability, and drawing on some of that learning theory in how we translate evaluation and research to the people that need to use it.
Right. I'm aware that we're running out of time, so I think perhaps I need to come to the panel briefly on those 2 points. So the translation one, and if anybody wants to add any more, add I to the 4 R's, possibly, the independence point. Who would like to go first? Anybody want to comment on those?
I think one thing that's just been going through my mind in all of this is that whoever you are undertaking evaluation, and yes, it needs to be done rigorously and appropriately, I think we need to just be careful about some sort of distinction between what universities do or academics do and what one might call others, which I don't even like doing that, or between what's funded by NIHR or other ways, because actually I used to be a health service manager. I'm now an academic. I do all sorts of different things. I work with different organisations. I spend some of my time working with the Health Foundation. Lots of us work in these multiple settings. And I think the applied research collaboratives that have been mentioned are one example of that. The commissioning support units are. I say so many others that I think it's just that it's kind of all of our business, that we're all doing this. And I think what we're trying to do is we're trying to sort out what works, aren't we, or what doesn't work, and use that evidence to sort of improve things or to stop things. And I think that's a really important point in our NHS that tends to want things to sort of become a bit Pollyanna-ish about things. But, sometimes about saying, do you know, because I'll be controversial for a moment, virtual wards is very equivocal evidence, and yet that's being, pursued with alacrity at the moment, it seems to me. But, having said that, there's quite a long evidence base on something like virtual wards. So, sorry, my other point here, so my one is about, it's kind of all of our business to develop this practice, but to keep holding ourselves to account about it. For those of us who are in academia, though, to be out there walking the walk and the talk, and I think a lot of us do a lot of the time. But this one about how we sort of do what the knowledge, whatever you want to call it, knowledge brokering, or synthesise the evidence and take stock of what's already known. I think that is such an important point, and I think I'm really taking that away this morning about that, because otherwise we're wasting all the kind of research and evaluation, that's been done. I think that's a really important one for me.
Great, thanks. Anyone else in the panel want to comment on those? Otherwise, we could possibly fit one more question in.
There's those boys in the back, aren't they?
Yeah, there was a couple of the back, the lady and then the gentleman. Thank you.
Hi, yeah, my name's Genevieve and I'm from the West of England Academic Health Science Network. I just wanted to share a bit of practice development that we've done locally in response to the question about the knowledge kind of brokering and mobilisation. So during COVID, our medical director led the development of an evidence repository directly in response to being able to kind of share some of the insight that was being developed. And we're still leading that with our local ICB organisations. And I've got a colleague here today who's a bit more involved in it than I am, so if anybody wants to find out more. But that's been a really good way for us to be able to put synthesis in, put kind of literature reviews, local evaluations. I think one of the challenges for us is then getting people to go to another place to find that evidence. But again, I think in the spirit of what Judith's saying, we are still learning about that. But it is proving popular, and we are definitely thinking about how to grow and continue to learn from that.
Mm-hmm. Thank you.
You said people don't trust the person.
Hi, Ben Newton, also with the West of England Academic Health Science Network. I was intrigued with Jen, my colleagues, talking about evidence repositories, but I guess we already have systems of publishing in journals, and I'm just intrigued what you think are some of the barriers for evaluators publishing in academic journals.
Great, so two good questions there. Oh, and one more. Joe at the front here. Thank you.
Thank you. Jo Ellins, University of Birmingham. I'm sort of mulling what seems to be a bit of a tension here, which is between, the emphasis on learning systems and the importance of evaluation, and I think we'd all agree with that, versus your Leeds example of very limited capacity. I mean, it is the bit of an elephant in the room, is with we're very limited in the world of evaluation in terms of teams with real deep expertise to do this. I'm also minded of Charles's point about prioritisation, making sure that we focus on the genuinely promising things. If we've got limited resource, we have to focus it. And I suppose not just a question for you, Charles, but a question for the panel is, how do we make sure that happens?
Great. So anybody want very briefly to pick up on those points? We've just got a minute or two left. So prioritisation, where to focus, and publication of evidence, I think, might be ones.
there are so many ideas that actually all the questions that have been asked and your comment, Joe, just makes me think of so many things. I'm not quite sure where to start. Yeah, I think I think you're right. Like it's fine to say things don't work, and often you can do that quite quickly. And I think what we're all wanting to do is to find things that actually improve the health system. That's one thing. Obviously, stopping things that don't work will also help, but that's not maybe so hard to do. I think the kind of finding new opportunities. I personally think, but I think it depends what kind of role you're in. Evaluators have got a role in particularly if you're not like distant from the system, but if you're working within it to help that process of finding things, but also, as I was mentioning earlier, about actually shaping those ideas and shaping them with evidence from previous evaluations. Actually, I had one other thought that probably doesn't answer it fully, Joe, I know, on independence. And I think so I think we all agree independence is really, really important. It kind of is very important for actually being able to tell the truth, but also having credibility. I think there's also, of course, this tension between independence and being seen as being helpful to the system. Because I think sometimes what independence doesn't mean is that we're putting a hat on and judging initiatives. It's about being independent, but also seen as being on kind of the same side, as in we all want to be in a position where we're helping health services improve. And I think that is a really, really important thing to always tell the kind of people who are kind of commissioning evaluation, to help them understand that, and to help them understand that actually by telling the truth and being independent, that will help create a learning health system.
So that is a fantastic endpoint for the panel, and I hope that's given you lots of ideas and things to take into the rest of the session. So thank you very much to everyone who's asked questions. But thank you. Time for clapping now to our fantastic panel.